Welcome to our video on how to get rid of a cutaneous fungal infection. If you have ever suffered from a cutaneous fungal infection, you may be wondering how to get rid of it. You might have heard about mucormycosis or jock itch but don't know where to start. This video will explain what each of these conditions is, how to treat them, and what you can do yourself to get rid of them for good. Listed below are a few treatments that will help you get rid of your infection for good. Tinea pedis. Patients with tinea pedis often present with pruritic, erythematous, inflamed areas on the foot. In some cases, the infection can be vesicular, interdigital, or moccasin type. It may also be caused by dermatophytes and is spread by contact with insects or other animals, including fomites. However, if the infection is suspected, pharmacists can work with primary care providers to provide appropriate treatment for patients. Treatment for tinea pedis involves the use of topical antifungals, including azoles and allolamins. These are effective in treating cutaneous fungal infections caused by the fungi that cause tinea pedis. However, azoles, terbinafine, and naphthafine are also recommended for this condition. Lastly, patients should avoid prolonged exposure to excessive moisture. Avoid walking barefoot in public areas, locker rooms, or showers. Affected individuals should wear non-occlusive shoes, absorbent socks, and apply powder to control the amount of moisture on their feet. During the early stages of the disease, the patient should wear loose-fitting clothing with good wicking properties. The same goes for socks and underwear. To minimize the risk of reinfection, patients should avoid walking barefoot and sharing clothing with others. The CDC website contains more information about fungi and their treatments. It's recommended that patients follow the recommended steps as closely as possible to prevent reinfection. People with an impaired immune system or HIV should undergo proper diagnosis and treatment of this condition. If tinea pedis is left untreated, the infection may become resistant to treatment. During the later stages of the infection, the fungal infection can spread to the toenails and skin of the dorsum of the foot. Once the infection is diagnosed, the infection may recur several months later. The most common symptoms of tinea pedis in children are vesicles and fissures in the web spaces. It can also cause generalized scaling of the soles. Positive co-scraping and fungal culture are essential for diagnosis. The symptoms are usually obvious. Treatment options for tinea pedis include topical creams and oral medications. For more severe cases, doctors may prescribe an oral medication. Mucormycosis. Cutaneous fungal infection is caused by fungi on the skin. Mucormycosis affects mostly the sinuses and lungs, but it can also spread to other areas of the body, including the eye, kidneys, and bones. It typically causes painful, hardened patches on the skin, and nearby skin may become red, swollen, and painful. It can also lead to blisters and open sores. During the course of mucormycosis, affected individuals may experience a fever. Treatment for mucormycosis is multidisciplinary and may include intravenous antifungal medications, surgical excision, or a combination of these treatments. Although no specific medication has been approved by the FDA to treat mucormycosis, many treatments are available for the infection. The first step in treatment is typically intravenous antifungal medications, followed by surgical debridement. Surgical debridement removes infected tissue and has been shown to prevent the recurrence of infection. Patients who respond well to FOR therapy can also be given oral antifungal medications. The fungi that cause mucormycosis are part of the Mucorales order. These fungi are ubiquitous in the environment and are capable of rapidly growing and releasing spores, making them common contaminants in clinical microbiology labs. Mucorales fungi are abundant in the environment and are found in all human beings during their daily activities. A mucormycosis infection is rare, though it is often caused by an underlying compromising condition. The diagnosis of mucormycosis can be confirmed by biopsy or culture of the infected tissue. Surgical debridement must be performed with a negative margin for fungal elements. If the biopsy is performed for suspected mucormycosis, a portion of it should be cultured on a fungal medium. Although fungal blood cultures are negative, serologic tests are not available to confirm the diagnosis. The causes of mucormycosis are unknown, but the disease has been shown to increase among patients with immune-compromised conditions, including patients receiving hematopoietic cell transplants or solid organs. The incidence of mucormycosis has increased in recent years due to a high HIV prevalence and widespread organ transplantation. In patients with hematological malignancies, sporangiospores may emerge after the transplant procedure and may cause the patient to relapse. Jock itch. A cutaneous fungal infection causes jock rash on the lower leg and buttocks. It can spread to the other areas of the body, including the buttocks and abdomen. It rarely affects the scrotum. Prevention is key to preventing jock itch. Wash your underwear after each exposure to water. Also, don't wear tight, chafing clothing. Tight clothing is conducive to fungus growth. Jockey itch can be a chronic condition that can last for months without treatment. However, it is not life-threatening. Antifungal medications can effectively treat it. Medicated creams, powders, and sprays are available. Always follow the directions on the medicine label. Stopping treatment prematurely may lead to a recurrence of the infection. Some people even use medicated products to prevent it from coming back. A cutaneous fungal infection causes jock rash on the groin area. The fungus that causes jock itch thrives in warm, moist areas, such as the inner thighs. It can be transmitted through skin-to-skin contact, sweat-soaked clothing, and scrotum-infected objects. A doctor may prescribe a stronger medication for severe jock itch. Treatment for this fungus is easy. Different medications will be prescribed depending on the type of fungus found on the skin. The most common treatment is a special cream or medication that will clear the infection up in a few weeks. The symptoms of the infection will go away with proper treatment. However, some people may not be able to stop the itching for a long time. However, good skincare is crucial to prevent tinea. The fungus responsible for jock itch is Trichophyton rubrum. It can affect people of any age and is very common among men. Infections caused by Trichophyton rubrum are common in warm, moist climates. The fungus can spread through clothes, socks, and towels. If left untreated, it can lead to a life-threatening disease. Treatment for Tinea cruris involves drying weeping areas and applying topical antifungal creams. In the case of a Candida superinfection, the application of nystatin powder, which has anti-infective properties, is useful. Treatment may require a cure for concurrent dermatophyte infection. Tinea cruris typically affects men more than women. It typically starts in the crural folds and extends outward from them. A number of antifungal creams in the formulary are effective for Tinea cruris. Typically, treatment requires about 10 days. Many creams are also formulated with allolamins, which can cure the infection in as little as 2 weeks. Mucorales spp. The invasive fungal disease mucormycosis is caused by fungi called Mucorales spp. Mucorales are opportunistic and mostly infect decaying plant material. Very few studies have been done on the environment of Mucorales, making this an excellent time to learn more about the fungal community. A small number of Mucorales species are associated with disease, but the severity of the condition is high and mortality is high. The virulence of Mucorales was studied in the laboratory, using 8 pathogenic species of these fungi. In this study, oxidative stress, osmotic stress, and menadione induced the bacteria to exhibit various responses. The maximum oxidative stress resistance was observed in Mucor racemosus and Cunninghamella bertholletii. The virulence of Mucorales was also influenced by iron concentration and spore size. There was a positive PCR test for the detection of Mucorales spp, though this test is not reliable. Only Mucorales can be detected by this method. Because Mucorales do not produce a specialized glucan, the fungi tested are not reliable for diagnosis. Aspergillus species and Mucorales spp. are more difficult to diagnose using conventional culture. This is why Mucorales spp. should be tested using other methods. Different genera cause mucormycosis. Some of these Mucorales species are sensitive to azoles in vitro. Therefore, lipid amphotericin B formulations remain the primary treatment for patients with COVID-19 associated mucormycosis. A patient's serum iron concentration increases when COVID-19 and ketoacidosis are co-diagnosed. When it is positive, a Mucorales-specific T cell will produce an antifungal response. The invasive fungal disease mucormycosis is characterized by filamentous growth and inflammatory processes. The infection is characterized by high mortality and poor therapeutics, reflecting the inability of the human immune system to clear the disease. The immune response to Mucorales depends on the development stage of the spore. Swollen spores are vulnerable to degradation by macrophages. In addition, immune suppression reduces neutrophil and macrophage activity. To evaluate Mucorales SPP, the mucor fungus has been studied in mice. The pulmonary infection model is useful in evaluating pathogenesis and virulence. Mucor SPP have also been studied in a systemic infection model using Drosophila melanogaster, Galleria melanella, and Caenorhabditis elegans. Thanks for watching. Please like, comment, and subscribe if this was helpful.